Mayong hapon kaninyong tanan. Good afternoon from Cebu City. Welcome to the 12th Biennial Symposium of the Philippine Foundation for Lung Health Research and Development Incorporated. This is in cooperation with the Philippine Heart Center Division of Pulmonary and Critical Care Medicine with the theme Exploring the New in Pulmonology. I am Dr. Arnold Nicholas Lim, and I will be your moderator for tonight's session. Reminders to all the attendees, you may type in your questions regarding the lecture in the chat box and the speakers will gladly answer them for you. Or you may personally communicate them by sending a message to the email provided on the screen. We would also like to request everyone to answer the evaluation form after the last speaker of the session. Link will be seen in the chat box. Let me start off by introducing our Twilight Symposium speaker. Our speaker for tonight is a fellow of the Philippine Pediatric Society. She is also a fellow of the Philippine Academy of Pediatric Pulmonologists and a fellow of the Philippine Society of Critical Care Medicine. She had her fellowship on pediatric pulmonology and critical care medicine at the Philippine Heart Center. She is currently the section chief of the pediatric pulmonology at the Philippine Heart Center. To talk about bronchial asthma in children, let us give a virtual welcome to Dr. Maria Dulce Requiron Sy.
A pleasant good afternoon to everyone. My topic is one of the most controversial diagnoses in children because we see a lot of children coughing but not wheezing and are not diagnosed as asthma. Some are diagnosed asthmatic because of the presence of wheezes on physical examination. My disclosure is that I'm a lecturer on asthma and ICS LABA of AstraZeneca. And the objectives of my lecture would be to present the latest guidelines in the management of bronchial asthma in children, to discuss the medical and non-medical recommendations in the management of bronchial asthma, and to present some of the common misconceptions about pediatric asthma and what do we say about them. Asthma is defined as a heterogeneous disease characterized by chronic airway inflammation. Heterogeneous because it could have several etiologies. Symptoms of wheezing, shortness of breath, chest tightness, and cough that vary over time and in intensity define it. Plus, there should be variable expiratory airflow limitation, and this needs to be documented by pulmonary function testing. So who among these children are really asthmatics? Asthma is diagnosed in children 6 years and older and adolescents when more than one of wheeze, shortness of breath, chest tightness, and cough are present and has the following features. As mentioned, there should be more than one of these respiratory symptoms, and symptoms occur variably over time and vary in intensity. Symptoms are often worse at night or on waking, and symptoms are often triggered by exercise, laughter, allergens, and even cold air. Also, symptoms often appear at worst or worsen with viral respiratory infections. And we will see later that the episodes of respiratory infections are significantly counted to determine the probability that a young child could be asthmatic. In addition to these signs and symptoms, expiratory airflow limitation has to be documented, as well as excessive airflow variability. And this is through pulmonary function testing. Excessive variability in lung function could be any one of the following: a positive bronchodilator reversibility test, excessive variability in twice daily peak expiratory flow over 2 weeks, significant increase in lung function after 4 weeks of anti-inflammatory treatment, a positive exercise challenge test, a positive bronchial challenge test, and excessive variation in lung function between clinic visits. And among these, the most commonly performed, especially among children, is your bronchodilator reversibility test. Talking about younger children, a confident diagnosis of asthma in children 5 years and younger is more challenging because episodic respiratory symptoms such as wheezing and cough are also common in children without asthma. Besides, spirometry cannot be performed as it entails following instructions. A probability-based approach is therefore recommended using the pattern of symptoms between and during viral respiratory infections. Remember when I mentioned about counting these episodes? Since younger children also will have more difficulty expressing if they experience chest tightness. Only wheeze, heavy breathing, and cough are used in its diagnosis. Among children with symptoms, less than 10 days only during an upper respiratory tract infection, when these episodes occur at the most 2 to 3 times per year only also, and when there are no symptoms between episodes and no personal and family history of atopy, only few of these children have asthma and will have asthma in the future. And such episodes can be regarded as viral-induced wheeze, a post-infectious inflammatory condition. If the symptoms would last for more than 10 days during an upper respiratory tract infection, and episodes are more than 3 times per year, or even if less, but are severe ones or associated with worsening at night, and occasionally symptoms occur between episodes, meaning there's a possibility that the patient doesn't really get asymptomatic, even in the absence of personal or family history of atopy. Some of these children could be asthmatic eventually. Aside from symptoms persisting for more than 10 days during an upper respiratory tract infection, also with more than 3 episodes per year, if they occur during the usual activities of play and laughing, and especially in the presence of personal and family history of atopy, like atopic dermatitis, food allergies, and asthma in a family member, asthma is most likely in these children. Most children with this are also probably asthmatic at the moment already. After diagnosis, how is asthma managed in children? Once asthma is diagnosed, treatment should start. And the stepwise management approaches that follow are used, and starting treatment depends on the symptomatology. And so with children 5 years and younger, we also make use of the symptomatology to determine at which step they should be started on. Asthma management also needs to be personalized. Confirmation of diagnosis is necessary, including differential diagnosis if the patient will not respond to medications. Wrong inhaler technique has to be assessed every time also, as this can lead to uncontrolled symptoms. Aside from going into symptomatology assessment and pharmacological management, patient and parent preferences and goals are also taken into consideration during the assessment and every time the patient would follow up for reassessment. Non-pharmacological strategies are also looked into. What triggers asthma attacks differ between each patient, and finding this out is part of the adjustment every time that the patient would come for follow-up in the clinic. And when you review patient response, patient and parent satisfaction also need to be assessed. This is also every time that the patient would follow up in the clinic. Now, the following are some of the non-pharmacological recommendations that should be taken into consideration seriously and every time, because some patients continue to experience exacerbations even with maximal doses of medications. Exacerbation risks can be reduced both by optimizing asthma medications and by identifying and treating modifiable risk factors and any avoidable triggers for exacerbations. Smoking cessation by the patient and any family member, also providing them with advice and resources regarding this. Weight reduction for obese patients, helping them to distinguish symptoms from deconditioning, mechanical restriction, and sleep apnea, and making sure that what they have are really asthmatic symptoms. Also, major psychological problems need to be addressed, arranging for mental health assessment and helping patients to distinguish again asthma symptoms from symptoms of anxiety and panic attacks. In the presence of confirmed food allergies and food chemical sensitivity, avoidance should be advised until asthma control improves. Identifying and eliminating occupational sensitizers as soon as possible is also very important. Encourage patients with asthma to consume a diet high in fruits and vegetables for its general health benefits. Encourage also people with asthma to engage in regular physical activities for its general health benefits, but this is as long as their asthma is already well controlled. Encourage people also with asthma to use non-polluting heating and cooking sources in their homes and for sources of pollutants to be vented outdoors where possible. All children, whether they are already diagnosed as asthmatics or not yet, 5 years and younger who experience wheezing episodes should be managed with your inhaled short-acting beta agonist for the relief of symptoms. But this is only for those patients with infrequent viral wheezing and with no or few interval symptoms only. They have what we call as viral-induced wheeze, which is post-infectious and should resolve spontaneously in a few days or a week or two, as long as no other triggers and no other viral infections would set in. Now, in the stepwise management approach, that kind of patient would fall in step one. So at this point, an inhaled corticosteroid may not really be necessary. If inhaled short-acting beta agonist, however, is not sufficient, particularly those with underlying atopy and symptoms would persist or recur several times a day, intermittent high-dose inhaled corticosteroids may be considered. Now, in one study, budesonide at 1,600 micrograms per day, preferably divided into 4 doses over the day and given for 5 to 10 days, may reduce the need for oral corticosteroids and prevent worsening of this exacerbation. When symptoms, however, would occur more frequent now and as needed relief with your short-acting beta agonist is not enough, like when the symptoms would occur more than twice a week over a 1 month period, say in the last 3 months, at least there is now a need for a trial controller medication with your inhaled corticosteroids. The patient can be started on low daily dose for a few weeks or maybe 2 to 3 months, but this is only as a trial controller medication and not really for maintenance yet. So reassessment would always be necessary. Now, the most commonly available inhaled corticosteroids locally are in this table. Note that budesonide is recommended to be delivered by nebulization, and also it is the only one recommended for children as young as 1 year of age. Take note, however, that this is not a table of equivalence, but are the lower approved doses for which safety and effectiveness have been adequately studied in this age group of children 5 years and younger. So budesonide can be started by nebulization at 250 micrograms, that is half a respule, given twice a day. But if the patient is 4 years old and older, another option is fluticasone and beclomethasone given by your pressurized metered-dose inhalers. Having symptoms as much as more than twice a week over the last month, although the patient could still be in step one. Now the patient is already either having an exacerbation here or may even be having a worsening of the asthma and might need to step up to step two. Now your assessment of the patient determines whether a controller is already necessary at this point or not yet. Now, with further progression of a patient's symptomatology, if the symptom pattern is not consistent with asthma yet, but wheezing episodes requiring short-acting beta agonists would occur more frequently, meaning the patient might have 3 or more exacerbations per year. You manage the patient already under step 2, and you give low-dose inhaled corticosteroids, but this can be also a diagnostic and a therapeutic trial for the next 3 months. Most of the patients here, I believe, would be coming back to you already for at least a year and had already been observed, and you are able to document chronicity. In other situations, however, if the symptom pattern is already consistent with asthma, and the patient had already been diagnosed as an asthmatic, and the symptoms, however, are not well controlled or are occurring for more than 3 times or equal to 3 times per year at least, daily dose of your inhaled corticosteroids should also be started. However, this time it's not going to be a diagnostic or therapeutic trial anymore, but already as a maintenance. In subsequent follow-up of patients, and you see that there will be no improvement or there might be a worsening of the symptoms, you need to step up to step 3 and give the patient low-dose inhaled corticosteroids in the double dose. Or another option would be to add your leukotriene receptor antagonist to your low-dose regimen. And then at this point, I believe you need to start thinking of referring to an asthma specialist, maybe a pediatric pulmonologist. Now, especially if you need to go up to step 4, okay? Because the patient doesn't respond even to doubling of your inhaled corticosteroids. This uncontrolled or worsening of symptoms could already be an asthma exacerbation, but it could also be the start of an undiagnosed asthmatic who frequently wheezes to finally be diagnosed as one. In the management of children 6 to 11 years, you also look at symptomatology. For patients with infrequent symptoms, say less than twice a month, and even those with more than twice a month, but less than daily, patients are managed under steps 1 to 2. That is taking inhaled corticosteroids whenever your short-acting beta agonist is taken. So still PRN, although we should take into account the likelihood of poor adherence in children with infrequent symptoms because they also infrequently would use their medications. Now, another option here is, if you worry about that, is you can put the patient already on maintenance with your daily low dose inhaled corticosteroids. But there's one thing with the PRN inhaled corticosteroids with SABA, because interviews with parents indicated that those whose children were randomized to as needed ICS SABA felt more in control of their child's asthma. And that is already a positive feedback to use this PRN short-acting beta agonist ICS combination management step. When they have symptoms most days, or they cannot sleep or are waking with symptoms of asthma, management is already at step 3, the stage at which most patients would decide to seek consult because symptoms are persistent, not only persistent, but they are getting worse. The recommendation here would be to use any one of the following as maintenance, not a therapeutic trial, not a diagnostic trial. You can start the patient on low-dose inhaled corticosteroids with your long-acting beta agonist, any one of them. Your steroid can be given at 100 to 200 micrograms of, for example, budesonide by inhaler per day. Now, you can also double the dose and maintain the patient on 200 to 400 micrograms of your inhaled corticosteroids, budesonide per day. That is medium dose ICS without using your long-acting beta agonists. Well, another option would be to put your patient or to start your patient on very low dose inhaled corticosteroids, but you use formoterol as your long-acting beta agonist. The steroid dose here would be at 100 micrograms and formoterol would be at 600 micrograms. And then you can use the same gadget for controller and also for exacerbations whenever the patient would have an asthma attack. Okay, and that is what we call as maintenance and reliever therapy, or MART. Well, another option is you can also maintain the patient on low-dose inhaled corticosteroids, but instead of giving a long-acting beta agonist or a bronchodilator, you start the patient on your leukotriene receptor antagonist. Now, you can choose between all of these maintenance protocols. Now, for flare-ups or exacerbations, You use the same gadget, as I have said, in MART or maintenance and reliever therapy. Or you can start also giving the patient your short-acting beta agonist. However, if symptoms are not adequately controlled as needed with this low dose ICS LABA or even with your SABA or with your MART, you need to go up to step 4 and double up or increase the dose of your inhaled corticosteroids to medium. Well, at this point, you also need to start thinking of referring your patient to an asthma specialist because the patient might not be really improving, and further investigation will have to be done regarding asthma and the patient's response to medications. Again, the commonly used inhaled corticosteroids for children 6 to 11 years of age are in this table. Again, this is not a table of equivalence, but of estimated clinical comparability. Now, studies have shown that most of the clinical benefits are seen at low doses. And a low daily dose is defined as the dose that has not been associated clinically with adverse effects in trials that included measures of safety. Now, let's take a look into the misconceptions on asthma in children. And these are some of the explanations that you can give when such concerns are raised in the clinic. Asthma medication is addictive. Now, because people are scared to continue, scared of the side effects, which they have not experienced yet, most probably, and just heard of. Not maintaining on the necessary medications, especially inhaled corticosteroids, can worsen the airway inflammation. That is one thing that you have to explain to the patient, and requiring a higher dose every time the patient would consult. So explain to them that the patient needed to be maintained on inhaled corticosteroid. Another one is asthma medication becomes less effective over time. This is true with patients who use only a short-acting beta agonist. They usually develop tolerance or what we call as tachyphylaxis, but this does not happen when proper maintenance medications are taken, especially your inhaled corticosteroids. So you cannot really make use of your beta agonist every time that the patient would just have an attack. Steroids are dangerous to health, even inhaled ones. But inhaled medications are only locally absorbed. Studies have shown that. And with proper follow-up and monitoring, the dose is also tapered off to the lowest, most effective dose for that particular patient. Patients should also avoid taking more than the safe prescribed dose so as not to have systemic absorption. Because, for example, with budesonide given at more than 2,000 micrograms per day, there will be systemic absorption already. Everyone outgrows childhood asthma. No, because once an asthmatic, always an asthmatic. Maintenance will be necessary. But remember, treatment is both pharmacologic and non-pharmacologic. So avoidance of triggers which might entail lifestyle and behavioral changes can can actually help in the management of these patients. Also, children, especially males and less than 5 years of age, when they grow, their airways also grow in size and the airway muscle tone also decreases. So they will be experiencing less bronchoconstriction. Besides, these children at the most are diagnosed only to have probable asthma when they are 5 years and younger only. A child with asthma should not be allowed to play like other kids and shouldn't take gym class or play sports. Remember, one of the ultimate goals of asthma management is to bring back these children to do physical activities. That is why maintenance is really necessary. And as mentioned in the non-pharmacologic recommendations, patients with asthma, even children, should be encouraged to engage in regular physical activities for its general health benefits. But this is only as long as their asthma is already well controlled. And most probably that is with inhaled corticosteroids already. Asthma is treatable only when symptoms are present. The management of asthma has already stepped up in the last several years because based on studies, inflammation is present even in mild and intermittent asthmatics. That is why, even at step 1, even when symptoms are less than twice a month, there is already a recommendation to maintain on low-dose inhaled corticosteroids. Otherwise, symptoms will worsen with time. And last but not the least, if you aren't wheezing, it isn't asthma. Remember, this not all that wheezes is asthma, and not all asthma wheezes. The criteria for its diagnosis is the presence of at least 2 of cough, shortness of breath, chest tightness, and wheezing, and not always involve wheezing only. Okay, so my take home here for you all is that asthma can be controlled and it has to be controlled. Now, all of this, my reference is the Global Initiative for Asthma, updated 2021. So I hope you start reading them and enjoy reading them also. Thank you for listening.
Thank you, Dr. Requiron Sy, for that very insightful lecture. So if you have questions for Dr. Sy, you may type it in the chat box and our speaker will gladly answer them. Now, at this point, we would like to present the certificate of appreciation to Dr. Maria Dulce Requiron Sy for being our speaker in the 12th Biennial Symposium, Exploring the New in Pulmonology, given this 16th day of September 2021, signed by Dr. Cesar Antonio Ligo, President of the PFL HRD, Dr. Eileen Banzon, Head of the Division of Pulmonary and Critical Care Medicine, and the members of the organizing committee.